Hello, this is Farah Douglas, CEO and Executive Director of the Liver Wellness Foundation. Welcome to our Meet Your Liver Doctors webinar. Thank you for joining us. The mission of Liver Wellness Foundation is to provide life-saving information on liver wellness, promote prevention of liver disease, advocate for quality patient care, and host community and physician-centered educational programs and services to meet the needs of the local liver patients and our hepatologists. Our vision is to strive for a day that liver disease and death from liver disease becomes a faded memory. We are a California-based foundation. Our Medical Advisory Council, led by Dr. Saab from UCLA, has 37 members who are the best hepatologists and liver specialists in the United States. Our board of directors and founding members have been in liver space, supporting and helping liver patients, some of them for over 2 decades. Our promise to you is to be transparent and dedicated to liver patients. We will use the funds we raise to educate and provide support services to our local patients. Please let me emphasize local, because the funds we raise will not go to any other organization in any other part of the country. We are here to serve you. Tonight's webinar is the second part of a 3-part webinar on liver cancer. The focus of the presentations is patients, their caregivers, and family members. We look forward to hosting these programs in person as soon as they tell us it's safe to do so for us and for you. I want to thank Dr. Sami Saab, our host and MC, Dr. Michael Volk, our presenter, and our sponsors, Eisai and Exelixis. Thank you. Now I want to introduce David Schmal, Senior Oncology Account Manager at Exelixis. David?
Thank you very much for the warm welcome, Farah. Yes, David Schmal with Exelixis here. Exelixis is a company that was founded in 1994. We're an oncology-focused biotechnology company, and we're dedicated to discovering and developing medicines that will be able to help very challenging cancers. And so we've established ourselves with a product called Cabometyx, and Cabometyx is indicated across multiple tumor types, but more specifically, and apropos to this evening's webinar, we're indicated in the HCC, or hepatocellular carcinoma space. So we're deeply committed to the hepatology space. Very honored to be able to sponsor the Liver Wellness Foundation, and hope to impact and benefit a lot of patients here this evening. So thanks again for the opportunity, Farah and Dr. Saab and Dr. Volk. Looking forward to hearing your presentation. Thank you very much.
Thank you, David. Again, we appreciate Eisai and Exelixis for the support of our foundation. It is now my distinct honor to introduce the chair of the Liver Wellness Foundation's Medical Advisory Council and the MC and host of tonight's program, Dr. Sami Saab. Dr. Saab is the Medical Director, Flagler Liver Institute, Medical Director, Adult Liver Transplant Program, Chief Transplant Hepatology, Head Outcomes Research in Hepatology, Professor of Medicine and Surgery, Adjunct Professor of Nursing, Professor, California North State University College of Medicine, Associate Editor for Liver Journal of Clinical Gastroenterology. These are just a few among many titles that Dr. Saab carries. Thank you, Dr. Saab, for your support of the Liver Wellness Foundation. You have been with us from day one, and we really appreciate all that you are doing for us. Thank you.
Well, thank you, Farah, for that kind introduction. And I also want to highlight David and Aaron for a great presentation and for their ongoing support and their advocacy for patients through the Liver Wellness Foundation. It gives me great pleasure to introduce a dear friend and colleague, Michael Volk, who I've known now for many years. He's director of transplantology and division head of gastroenterology and associate professor of medicine at Loma University. He's a board certified in transplantology, gastroenterology, internal medicine. He's been frequently selected as one of the best doctors and top hepatologists in the country. Prior to coming to Loma Linda, he was at the University of Michigan, where he was director of liver tumor program. He's a former Robert Wood Johnson clinical scholar and has a long track record of research and receiving grants. It's hard to believe, but in the short span of 6 years, or rather in 2015, he's already quadrupled the size of the transplant program there for liver, from about 25 per year to over 100 per year. He's also led to exponential growth of GI division from 8 faculties to 17, and has been instrumental in establishing very successful clinics to make it easier for the patients in the community, satellite clinics, to receive expert care through a combination of academic and private partnership. His clinical focus, transplantology, liver cancer. His research interests are on health utilization, delivering the best care possible for people with liver disease, and also looking at organ allocation. As I mentioned, that deaths as a result of liver cancer and the incidence of liver cancer is on the rise. Dr. Michael Volk will take us through a personal journey of what patients experience when they have liver cancer. So without further ado, my good friend, colleague, Dr. Michael Volk.
All right, thank you so much, Dr. Saab, and hi, everyone. Hopefully we have some patience in the audience, because I'm going to give kind of a perspective of what it's like to journey through pathway of having liver cancer. Let me inflate this. So we're calling this a patient journey. So we're going to start with an overview of how patients are diagnosed with hepatocellular carcinoma, or HCC. This is what we call liver cancer. And then the experience of undergoing treatment from a patient perspective. So first, a little background. HCC is actually super common. It's the 3rd leading cause of cancer mortality worldwide. It's the 10th leading in the US. And you can see that in some areas of
sorry
the
to
world,
interrupt. We cannot see your screen.
Oh, okay. Let's see, try this again. All right, share screen again. Is this working now?
Yes.
All right. So,
Perfect. Thank you.
okay, thanks. Sorry about that. So you can see that some areas of the world, it's much more common, such as sub-Saharan Africa and Southeast Asia. And that's primarily driven by high rates of hepatitis B in those areas. In California, where we are, it's one of the highest incidence in the United States. So the West Coast and the South have the higher incidence areas. And this is driven by viral hepatitis. So hepatitis B and C accounts for about 2/3 to 3/4 of hepatocellular carcinoma in the United States. And then the remainder is primarily caused by NASH, non-alcoholic fatty liver disease. This is increasing in frequency. And just as an aside, about 1/3 of Americans have fat in their liver, and we call that steatosis. You can see the picture here. But only a small fraction, fortunately, will develop fat plus inflammation, so steatohepatitis, and that can lead to cirrhosis and liver cancer. So we're definitely seeing that more and more frequently, unfortunately, with the obesity epidemic, and now that we're able to treat more and more patients with for their hepatitis C. So we'll start with a case, Mr. J.S., 67-year-old man, so he's a baby boomer, they have high rates of hepatitis C, and he's what we call compensated. So although he has cirrhosis, means scar tissue in the liver, there's no bleeding, no ascites or fluid in the abdomen, no confusion related to his liver disease. So for the most part, he feels relatively well. He was lucky to have Hep C that was treated in 2016 and eradicated, now that we're able to really cure most people of their hepatitis C. But he was following with a really good gastroenterologist who knows that even though the Hep C is treated, since he has cirrhosis, he is at risk for liver cancer. And so his gastroenterologist was screening him with an ultrasound and alpha fetoprotein. And on this every 6-month testing, he was found to have a new liver lesion or spot. We doctors, we call things lesions, spots. It's really all the same thing. It's something that we see on an imaging test that's not supposed to be there. So just an aside about screening. Patients with HCC really need screening. This is a randomized trial showing patients that got screened had a much better survival after diagnosis than those patients who didn't get screened. And that's because the tumor gets detected early. So early detection is key. If we detect it early, we can cure the patient, but if we don't detect it early, then usually we cannot. So when we find something on the screening test, then we have to say, is this HCC? And so we have to diagnose. And 3 key points in diagnosing HCC. The first is to consider the pretest probability, and that means what's the likelihood that this person will develop HCC? And so we know this is mainly in patients with pre-existing liver disease, like Mr. JS, who had hepatitis C. So, to reassure all of those of you who, if you happen to get a CT scan or an ultrasound for something and you have no liver disease and you're found to have a spot on your liver, it's probably going to be benign. But if you have chronic liver disease, then that's where you should be more concerned. Now, high quality imaging is the key. Most of the time we can diagnose just based on imaging. So this is with a CAT scan or MRI, and you have to have the IV contrast to make the diagnosis. Now, fortunately, we really only need to do a biopsy about 10% of the time. So the diagnosis and the treatment of HCC is based on the fact that the liver is unique in the body and having a dual blood supply. Most of the liver is actually fed by the veins, but liver cancer, HCC, produces a hormone that causes a lot of arteries to develop. And so the tumor is fed by a lot of arteries, whereas the rest of the liver is fed by veins. And so that's how we can tell if something is HCC. We do a scan and we give the IV contrast, and then we do a scan and various time periods after giving the contrast, so we can see when the contrast is in the arteries versus when it's in the veins. When it's in the arteries, the tumor looks brighter because it has a lot of arterial blood flow. And when it's in the veins, the tumor looks darker than the rest of the liver because all the contrast is in the veins, and so it's making the rest of the liver appear brighter. And so this shows a mass with arterial enhancement and washout, and that's how we diagnose HCC. If any of you have had a scan and you see a report where there's a spot on the liver, hopefully the radiologist is up to date on the latest terminology, and that's we use something called the LIRAD system. So if it's LIRADS 1 or 2, it's not HCC, nothing to worry about. LIRADS 3, indeterminate, meaning we've got to watch it. 4 is really suspicious, but we don't know for sure, so oftentimes we'll biopsy here. And 5 is diagnostic, and so that's definitely HCC. The staging of HCC is different than most cancers. It's not only driven by the size and number of tumors, but also by how the patient is doing, so their performance status and the liver function. And so that really guides how we manage the patients. And this shows the survival based on the stage. And so unlike most tumors that are stage 1, 2, 3, and 4, we stage liver cancer by A, B, C, and D. And you can see that patients with stage A, we can cure a lot of these patients. Stage B, we can only cure a small fraction. In stage C and D, we really can't cure anyone, but we can prolong their life and make their life more comfortable. This is a complicated slide just to show you that there's a lot of treatment options for HCC. We can do surgery, whether it be surgical resection, meaning cut off part of the liver. We can do transplants. We can do ablation. We'll talk more about that. We can do various treatments where we put in chemotherapy into the tumor or radioactive particles. We can give systemic therapies, such as you heard about earlier, or we can just focus on improving quality of life. So this is the complex algorithm that we use when we review patients in our tumor board, and we decide what's the best possible treatment for the patient. And we try to individualize to each patient. So going back to our patient, Mr. JS, he had a multi-phase CT scan showing a 5.2 centimeter LR5 lesion in the middle of the liver. So 5.2 centimeters. So, my thumb is about 2 centimeters wide. So it's a little bit more than 2 times the width of my thumb. So it's not huge, but it's a decent size. And, he's actually feeling okay, a little bit tired. Labs show that his bilirubin is mildly elevated and his platelets are a little bit low. He has an upper endoscopy showing that he does have varices, so dilated veins in the esophagus from the liver disease. So based on all this, we stage him as a stage B. So we'll talk about the different treatment options, starting with surgery, because that's the option that's going to be most likely curative. And so we always consider, is this patient a candidate for surgery? Can we cure them? And everyone always wants to know, why can't you just cut it out? And we can, but the problem is that oftentimes, depending on the size and where it's located, we have to cut out a big part of the liver. And if someone's healthy, you all may have heard, oh, the liver can rejuvenate, and that's true. If someone's totally healthy, has a healthy liver, you can cut out more than half the liver and it'll just grow back. But if the liver is not healthy, then it doesn't grow back very well. And so what we know is that if based on how bad is their liver function, based on their portal pressures and their bilirubin level, we know that patients may do very well if their liver disease is good, but if their liver function is not good, then they just won't tolerate surgery. So then, well, we think about, could we do a liver transplant? If they can't tolerate taking out part of the liver, what about if we just replace the liver with a new one? And so we've known for decades now that we can successfully transplant patients for HCC. And this is what was called the Milan criteria. And this has really stood the test of time. So patients with single tumors less than 5 centimeters or no more than 3 tumors less than 3 centimeters can get a liver transplant. As long as it doesn't invade the veins, it hasn't spread outside the liver, and overall their survival is really good. So going back to Mr. JS, he undergoes what we call local regional therapy, and we'll talk more about that as treatments to shrink down the tumor, because if you recall, his tumor was 5.2 centimeters, so just a little bit too large, just outside the Milan criteria. So we couldn't quite get a transplant yet. Just kind of so all of you know, these criteria are not something that I or Dr. Saab decide, in a back room by ourselves. These are national criteria, very standardized and very objective. So it's the same across the country. So Mr. JS has this treatment, and it's able to shrink the tumor down. You can see in this image that the area that's bright is now down to 3 centimeters. And so that's the part of the tumor that's alive. And you see the dark part of the side is just dead tissue. Now, some of you may have experienced, if you get a report, the radiologist sometimes might measure the entire tumor cavity, and that can really scare you because you might think that your tumor is the same size or even bigger. But we have to actually measure the part of the tumor that's still alive. So we've now managed to successfully downstage the patient to stage A from stage B. So that's awesome. So he now meets Milan criteria and can get on the transplant list. So let me just talk to you a little bit about what are these local regional treatment options that we can use to shrink down the tumor. So one is microwave ablation. So this is a needle that's poked from the outside through the abdominal wall in between the ribs or just above the belly button and into the tumor using imaging guidance. Patients are typically asleep for this. And these little metal tines are put out into the liver, and then using microwave, energy is delivered to heat up this area and burn the tumor. So it burns all this area without burning the surrounding liver or the patient's abdominal wall. And so the patient wakes up and is watched overnight, oftentimes sent home the next day, and that works really, really well. So that works great for smaller tumors. But when the tumor is a little bit larger, we can't really burn it. And so we have to use treatments that involve going through a blood vessel. So this is chemoembolization, or TACE, T-A-C-E, stands for transarterial chemoembolization. Again, we sedate the patient, we put a catheter through the blood vessel in the leg, it goes on up into the liver and injects dye, and we see here this tumor, and we inject chemotherapy particles. So it's not chemo throughout the whole body, it's just into the tumor itself. And then we shut off that blood supply so that the chemotherapy stays in the tumor. Again, patients watched overnight, goes home the next day, pretty well tolerated because the chemotherapy mostly stays in the liver and doesn't go throughout the whole body. A very similar treatment we can use is called, instead of chemoembolization, we can use radioembolization, so radioactive particles. And the radiation we use is called yttrium-90. The brand name is TheraSphere. And again, we put a catheter through the leg, snake it on up into the liver, inject these particles, watch the patient overnight, go home the next day. So all these treatments are good. They'll shrink down the tumor, they'll prolong survival, sometimes by years. But in most cases, the tumor will eventually come back. So for that reason, Mr. JS was put on the transplant list. And since he met Milan criteria, he could get exception points, meaning that he got bumped up higher on the list. We expected him to get transplanted soon. But unfortunately, just as he's about to get a transplant, he has a chest CT showing a new 1.5 centimeter lung lesion. So that's really unfortunate. It means that the tumor has now spread outside of his liver to his lungs. He's now stage C and no longer a candidate for transplant, because if we gave him a new liver, it really wouldn't help him because the tumor, the cat's out of the bag already. So we're now moving on to talk about systemic treatment options. Now, when Dr. Saab and I started doing this, there really weren't any systemic treatment options that worked. Patients would get chemotherapy and they just didn't tolerate it well, and it didn't really help them. But fortunately now there's a lot of new treatment options available. So it's kind of an exciting time. And there's treatment options that target multiple different pathways in the cascade of what controls growth of tumor. So I'll go through a few of them. As you heard earlier, the first one to be approved was sorafenib. And this was really a breakthrough in 2007. We were all very excited. You can see that it does improve survival, but gosh, not that great. We get an extra 3 months out of it. It's pretty well tolerated, but there are definitely side effects. So better than nothing, but it wasn't amazing. Now you heard earlier about Lenvima, and that's equivalent to sorafenib, but better tolerated. So that's pretty exciting option, libitinib. Then we also have another new combination of two agents that no one can pronounce, of course, but it's exciting because they improve survival even more than sorafenib. So it's a great time, in the field, and we're hoping that more and more new treatments will become available. And you can see a lot of these new treatments are even better tolerated than sorafenib. So patients are getting these at home, and they're able to go about their daily life. So Mr. J started on systemic therapy, and he was able to travel to Europe and spend time with his grandchildren. And at age 71, which is now 4 years after his diagnosis, he becomes jaundiced, and a CT scan shows tumor progression. He's now progressed to stage D. So it's unfortunate that we weren't able to transplant him and cure him, but he did get a few extra years out of the treatments, and he would not have lasted this long without the new technology. And he got to do a lot of the things that he always wanted to do and see his family. And so now, because he's not feeling well, and he's stage D, the really key is that we in medicine don't harm him with treatments that aren't really going to prolong his survival and just make him worse. And so that's why the concept of palliative care is so important when patients get to this advanced stage. So palliative care is not the same as hospice. It's really just a focus on quality of life. And there's this really important trial published in 2010 showing that people referred for early palliative care, even though the focus is on quality of life, not quantity, they actually have sometimes a better survival. And we think maybe that's because they're not getting treatments that are just going to make them sick and not really prolong their survival. So at this point, palliative care is really helpful and allows patients to have their last days at home with their family. So in conclusion, you saw from all the different treatment options that management of HCC requires a multidisciplinary approach. And so, hopefully all of you who have liver cancer are getting treated in a place where all of your doctors are getting together in a room and talking about it. Hopefully none of you are getting bounced from specialist to specialist. It really needs a multidisciplinary, everyone getting together and individualizing for the patient. And then finally, early detection is key to improving survival. So please get the word out for patients with chronic liver disease, especially those with cirrhosis, should have screening for liver cancer. And that is the end of the presentation. Look forward to your questions and comments.
Well, Michael, that was wonderful. It's a great journey. And I think you touched on a lot of points, from screening to diagnosing to management, and how you have to evolve with the changing clinical paradigm. So we have a number of questions. One question is that you found this on imaging. What is a role of blood tests? Do you know of any biomarkers or other tests we could use the blood for screen for liver cancer?
Yeah, so great question. So really important that patients who have cirrhosis are screened. And as we saw from the patient, even if the hep C is gone, there's still unfortunately a risk of getting liver cancer. And so the screening is with an ultrasound every 6 months and blood tests. And the blood tests are AFP, alpha fetoprotein, and there's some newer ones called DCP and AFPL3. Simple blood tests, but they definitely help detect the cancer earlier.
And another question was, the patient it looks like the tumor spread to the lungs.
Yeah, so when the tumor spread to the lungs, then we kind of assume that it's throughout the whole body because it had to get to the lungs somewhere, somehow. And so that's for that reason, to answer two of these questions at the same time, we can't really just target the liver, target the lung by, say, trying to burn or even transplant both organs, because there's going to be tumor somewhere else in the body. And so that's why the key there is systemic therapy.
Yeah. So systemic can mean like medicine through your veins?
Yeah, systemic meaning that you take a pill and it gets absorbed and goes throughout your whole body, or you get it in the vein, in the IV, and it goes throughout your whole body.
And then someone asked a question, if the cancer went to the lungs, can you transplant the lungs as well as the liver?
Right, no, because for that reason, that if we transplant the lungs and the liver, it's going to show up in another place. And so it really isn't worth putting the patient through that.
And then there's a question from the audience about someone's loved one had unfortunately liver cancer, and it went to one of the veins, liver called a portal vein.
Yeah.
How does that change your management?
Yeah, liver HCC really loves to go into the portal vein for some reason. And to treat that, we use either systemic therapy or sometimes, depending on how extensive, nowadays we're able to use that radioembolization or Therasphere and can work pretty well for that.
Yeah, we've used it too. We've had, it works pretty well, very well tolerated.
Yeah.
And then another question is from the audience is someone was asking about the multidisciplinary meeting you have. What does that mean and who's involved and how often you guys meet and what do you guys do in that meeting?
Yeah, it's really important. And I've evolved so much in my ability to manage patients with HCC because I meet weekly with a group that includes a medical oncologist, surgical oncologist, transplant surgeon, radiation oncologist, diagnostic radiologist, interventional radiologist, and it's all these different specialties, and you learn so much. And so it's really key to in complex cases, especially. So strongly encourage any of you who have liver cancer to make sure that your doctor works in a place where they have access to something like that.
And do all these specialists meet the patient, or does this happen after the patient leaves?
Not always. Some places the patient sees them, but usually it's just everyone gets together. It's most convenient and expedient, to get the patient their treatment ASAP. It's most efficient to just get everyone together in a room and review the case, and then the main doctor that saw the patient goes back and calls the patient and says, "Hey, we discussed your case, and then this is what we recommend going forward."
Wonderful. And then another question comes up, people who've had a liver transplant with liver cancer, how do you follow them? You do, someone asked about what you follow, do you do blood tests, you do old imaging, how do you follow these patients?
Yeah, so as you know, 5% of people who get transplanted for liver cancer, unfortunately, can have recurrence. It's only 5%, so that's great, but when it happens, it's horrible. I don't know what you do in your program, Dr. Saab, but in ours, we individualize, so we categorize patients into high and low risk. Low risk patients, we don't do any surveillance because, if you do too many CT scans, eventually you cause cancer, right? But the high risk patients, we do serial CT scans.
Okay, yeah, we kind of just lump them onto one category and follow them very closely. We follow them for up to 5 years.
Yeah, we do too. The high risk ones we do.
Yeah, are you guys? You mentioned systemic therapy. People who are considered, and how do you define high risk for our audience?
Risk factors for patients who get transplanted for liver cancer, patients are at highest risk for recurrence, or those that have on the explant. When we look at the liver that comes out, it has multiple tumors that are still alive. It's invading the veins in little small areas. If their AFP was high at the time of transplant, things like that.
Oh, and there's a question from one of the audience members that they had a tumor about 7 years ago. The last scan showed some suspicious spots. Is there an age cutoff for ablation?
No, not really. If not at all. If the patient is doing pretty well, then yeah, we've definitely ablated people up into their 90s.
We have too. But I guess it depends. I guess like you mentioned earlier, it depends on the size of the tumor, location, and like you mentioned very elegantly, it depends how robust someone is. And then let me see another question. But you mentioned lesion. What do you mean by lesion? You mentioned a couple of times in your talk.
Yeah.
What's a lesion?
Yeah, patients complain about that. We doctors use our doctor speak, and so lesion, spot, it just means something on the liver that we see on the scan that shouldn't be there. And so sometimes it turns out to be a cancer, and sometimes it turns out to be a big nothing.
A lot of people find it fascinating that a liver cancer get diagnosed and treat without a biopsy.
Yeah.
And I don't know about you, but I always, if I was a patient, I would take a very bitter pill to swallow, saying that I feel fine, and yet there's liver cancer in me.
Yeah, right. And so sometimes, some patients really want to know for sure, but we just have to convince them that the imaging really is that good, and You know, as you know, Dr. Saab, there's always a risk of seeding the tumor,
Yeah.
spreading it when we biopsy. And so if we
Yeah.
don't have to, it's really better not
Yeah.
to.
Well, Michael, I really liked your approach. I liked your style. This is very physician and patient friendly. I love hearing about the journey, and I love the way that the story evolved and how you're able to switch gears to really provide the best care possible to this patient.
Thank you. I think we have one more question here. It says, why must you shrink the liver tumor to qualify for transplant? Yeah, so, and that's because it's really just a surrogate for the risk for spreading outside the liver. If the tumor is big, then, and we can't get it shrunken down, then there's a much higher chance it's gonna already be spread out. And when we replace the liver with a new one, we put the patient on immunosuppression, the tumor just goes gangbusters, and that's really bad.
Yeah. Well, Michael, thank you again for the wonderful talk, and I'm going to pass on the mic to Farah to take us home. Thank you, Michael. Wonderful talk.
Thank you.
Thank you very much, Dr. Volk. That was wonderful, full of information that our people need. Again, I want to thank our sponsors, ESI and Exelexis. Thank you for your support. Please remember, on August 11th, it's part 3 of our liver cancer webinars. It's going to be handled by Dr. Imagawa. Unfortunately, Dr. Sami Saab won't be with us, but Dr. Gish has stepped up to the plate and is going to be emceeing that program. Dr. Imagawa will talk about liver tumor, whether they are benign or malignant, and also about secondary causes of liver cancer, as well as the rare liver cancer cases. So please visit our website and register for Dr. Imagawa and Dr. Gish's webinar. Again, thank you so much to our sponsor and all of our patients and audience who come with us every time we have webinar and support us and send their questions in. Thank you so much. Any more questions? Anything, Dr. Saab?
No, that was really good. Oh, sorry, that was really good.
Yeah, thank you very much.
Now, I like what Michael did. I like the patient journey. I think, Farah, I think we should copy this format for other things.
I agree, because it's such a puzzle for patients when they're diagnosed with any kind of disease, especially liver disease and liver cancer. So if we can continue this style of following a patient through different process and the steps that patient has to take with doctors. I thought the point that Dr. Volk made regarding not passing you from one specialist to another,
yes,
but having them all talk about you as a whole and come up with a decision is the best, because as a patient myself, I just hate to be tossed around from this doctor to that doctor.
Yeah.
I want them to agree with each other quickly and tell me what I need to do. So that was a wonderful point that Dr. Volk brought up.
He did a great job. That was great, Michael.
Thank you.
I love this format. We're gonna reproduce it.
Yeah, that's a good idea. And maybe even have a patient join in. Could also consider that as well.
Yes. We have talked about that, to have a patient to tell us their point of view.
That's a good idea. Yeah. All right. Well, Michael, have a great week, and thank you, Farah, for inviting us to participate. It was a great turnout today.
Thank you, Dr. Volk. Thank you, Dr. Saab. Thank you, ESIS, and thank you, Exelexis. Thank you, all of our patients and audience.